while my presentation is going to focus on pharmacotherapy, I want to remind everyone that for the management of obesity, we want to ensure that we're working together with a lifestyle intervention and not just pharmacotherapy alone. Um, as you can see in the slide, it is better together in order to get optimal results from an obesity standpoint. And so I just wanted to highlight that a little bit. So just before I jump into pharmacotherapy, we all know, kind of give you a little background about obesity because we're not spending much time on that. But really, obesity, as you all know, hopefully, is that it's a public health issue. Over 40% of adults in the US have obesity. And so this is why there's so much talk around obesity. And so pharmacotherapy is one of the ways you can manage obesity and help with weight loss. So historically, there's been quite a few medication in the market being used for pharmacotherapy. The focus of this presentation is really going to look at the newer therapies, the GLP-1s, the GIPs, but I did want to highlight some of the therapies that are approved and can be potentially used right now. And so we have what we call short-term therapy for obesity, and then we have long-term use for obesity. And so on this slide specifically, you see your short-term use, which is about 12 weeks of therapy for weight loss. Phentermine is one of the common ones that we've seen, but primarily for the short-term use, they're sympathomimetics. So they really work similar to amphetamines. They work by decreasing the patient's appetite secondary to CNS effect. The problem with phentermine and diethylpropion is that it's a controlled medication. And for patients who have cardiovascular disease, you want to avoid it in those patients because of the adverse effect that can be caused by those medication. Many of you may know that patients who have obesity tend to have additional medical conditions, one of which is cardiovascular disease. And so this is really a limitation of these medication. In addition, it's really approved for short-term use, so about that 12 weeks. And so because short-term therapy is not really consistent with current national guideline for using chronic management of obesity, there's really limited practice in using these medications. However, like I said, you do see it being used. In particular, a lot of times it has to do with cost effectiveness of the newer medications, which we'll talk about. But these are primarily the two short-term use medications. And then I'm going to transition over to long-term use medication. So historically, these are kind of the three buckets of medication that has been approved through the FDA for the use of obesity for long term, so beyond that 12 weeks. You can see here orlistat. Orlistat is the only medication that is available over the counter as ally. It works by essentially inhibiting the gastric and pancreatic lipase, which ultimately inhibits the absorption of dietary fats. It's not really recommended by the Gastroenterology Association in terms of their recommendation for use of medications in patients with obesity. There's a slew of adverse effects you have to think about. There's various different things you have to think about as it relates to orlistat use for our patients. Some of the considerations are listed here. For patients who's really not eating or not eating anything that contains fat, they really need to know that they shouldn't be using orlistat. And one of the biggest recommendations for those that are using orlistat is really to take it with multivitamins, especially fat-soluble multivitamins, because again, it inhibits the absorption of dietary fats. And fats are important in our body. It's just there's certain limitations in how much fat you need. The next drug, I remember giving this presentation when I was in pharmacy school. It was new when it first came out, Casemia. It's phentermine in combination with topiramate as an extended release product. Back then, besides orlistat, that was your drug, your go-to drug for obesity management. But we know what phentermine kind of works like. I mentioned that before in the previous slide. But the topiramate portion of it helps with appetite suppression and satiety enhancement through various different mechanisms. It's kind of unclear, but one of which is increase in GABA activity. These things work in the CNS, so it helps kind of suppress the appetite and make you feel like you're full. It is a controlled substance because of the phentermine. Ideally, it's used for patients who have migraines because topiramate is used for migraines. And so for patients who have obesity and migraines, Kismia is a great product to use in that patient because it kills two birds with one stone. As mentioned before, patients with cardiovascular disease is something that you want to avoid this medication in because of the phentermine component of it. The other thing to keep note of is that topiramate is teratogenic. So you want to think about that for your patients who are, what's the term? Basically, who could potentially get pregnant. And then the next drug that I'm going to talk about is Contrave, which you might see it being used for other things. It's a combination of bupropion and naltrexone. The effects is really not really understood in terms of the actual mechanism of how it helps with weight loss, but the idea is there's something that it triggers in the CNS that basically help with the weight loss. And so there's something with these drugs that trigger the brain to kind of regulate the food intake. But again, the effects are not fully understood. We just know that it does cause weight loss. Some considerations, again, these considerations are very high level. I can go into pharmacotherapy in detail, but with half an hour, I had to pick and choose what I think is important. So with Contrave, the patients who would actually benefit from Contrave is patients who's attempting smoking cessation or patients with depression. And that's because bupropion actually helps with those medical conditions. And then one of the biggest things for bupropion in general is that you want to avoid it in seizure disorders because it can lower the patient's seizure threshold. And so because Contrave have bupropion on it, it's definitely a medication you want to avoid with patients who have seizure disorders or at risk for having seizures. So these are kind of really high-level overview of what has been used from a short-term management versus a long-term management for obesity drugs. And then came what we're here for, the GLPs and GIP drugs. So here comes liraglutide is probably the longest drug, the drug that has been out the longest. Under a different brand name for use of diabetes. The approved brand name for liraglutide for the use of obesity is Saxenda. We've heard of semaglutide. It's all over the place, all over the news. Wegovy is the brand name that is used and approved for obesity. Newest to this bucket is a dual acting product, which has a combination of GLPs and GIP. You can see what the abbreviation is here. It's tirzepatide. The brand name that's approved for obesity is Zepbound. I'm going to talk about kind of the history around GLPs shortly because it wasn't initially used for obesity, but we found that it does help with obesity. And so this is kind of why there are specific brand names for these medication for the approval of obesity because its drug have been approved for other medical conditions such as diabetes, and it's approved under a different brand name. So like for instance, semaglutide, Ozempic, we've heard of Ozempic. That is actually FDA approved for the treatment of type 2 diabetes, not necessarily for obesity. Wegovy is the product that is approved for obesity. So what are GLPs and what are GIPs? They're basically receptors in your body that act as an incretin. Basically, what GLP does is these products activate GLP-1 receptors. So what does it do? It increases insulin secretion, it decreases glucagon secretion, and all of these are glucose dependent. So what that means is that it will this action will happen when when the body recognizes that there's glucose in the body. So after you eat, basically, essentially is what it is, as opposed to insulin, where when you give insulin, it works at all times, right? Regardless of whether there is glucose in the body or not. GLPs, they don't activate and work until there's actually glucose in the body. It slows gastric emptying and then it increases satiety. These all help with essentially weight loss in your patients who have obesity, irrespective of whether they have diabetes or not. The addition of GIP, which is glucose-dependent insulin nootropic polypeptide, it's a peptide. It improves white adipose tissue function and lipid handling, and so it actually increased insulin sensitivity in the fat tissues. Basically, is what it is. In addition to all of the mechanism that I spoke about before, it has the increase in insulin secretion, it has a decrease in glucagon secretion, it slows gastric empty, and most importantly, it increases satiety, which helps with our patients who have obesity. So these are kind of the newer product that's hot right now. Everyone wants it to kind of lose weight and things like that. And so the bulk of this presentation is kind of talk about these products and some practical considerations for you as a healthcare professional. So just to give you an idea of why it's a product that's being widely used right now, this is a great chart from Chaktor and the other authors in terms of looking at mean percent weight change for the various different products that we talked about. So you can see here, you see orlistat, phentermine topiramate, naltrexone, bupropion, your liraglutides, your semaglutides, and then your tirzepatides. So you can see for the most part, your newer GLP-1s, GLP, GIP, have a significant amount of weight loss. And this is actually looking at placebo, so just keep that in mind. These aren't head-to-head trials. These are data based on the drug being studied against placebo. So you're studying against basically an inactive product for those that are not familiar with what placebo is. Yeah, we see the phentermine topiramate as having a high percent change in terms of weight loss, which was why it was being used for an extended used pretty commonly before the GLP products came into the market for the approval of obesity. Liraglutide has been around for quite a while, primarily for the use of diabetes, but it was approved for weight loss prior to semaglutide and tirzepatide. But you can see the weight loss percent change isn't as high as your semaglutide and tirzepatide. And so you'll see why semaglutide and tirzepatide is being used more often now as opposed to liraglutide. Moving on. So I mentioned how I'll talk to you about the journey of GLP. I found this nice depiction from Drucker on the journey of GLP from discovery science to therapeutic impact. So back in the 1980s, they found that GLP increases insulin secretion. And then a decade later, they found out that it inhibits food intake. So with all that information, they're like, what can we do to figure out how to use this product as a pharmacological therapy for type 2 diabetes? So then in 2005, There was a product out that was approved for the treatment of type 2 diabetes. Specifically, it was exenatide. So when I was in pharmacy school, the only GLP that was available was exenatide. The problem with exenatide is that it has a very short half-life, and so and it was an injectable, and so it wasn't used as much. And that's also because it has a short half-life, you don't really see it being used as much in comparison to the other GLPs. But exenatide was the first GLP that was approved specifically for the treatment of type 2 diabetes. GLP wasn't approved for the treatment of obesity until much later. And so so basically almost a decade later, GLP was approved for the use of obesity, and specifically it was the liraglutide. And then they started to do additional kind of studies with GLPs. I talk a lot about kind of diabetes, and that's because diabetes and obesity kind of go hand in hand. Folks who have obesity tend to have, like I mentioned before, cardiovascular disease, but also diabetes and renal disease and many other disease. And so this is kind of why I kind of allude to diabetes a lot, because a lot of these products, again, were started as treatment for type 2 diabetes and then found benefit in patients who have obesity and found benefit in weight loss. And so this is kind of where we're at with the GLPs. So basically, for medications that's approved for diabetes, they have to do a cardiovascular safety trial. So they look at cardiovascular, not just safety, but kind of outcomes as well. And so you can see why in this timeline that there's cardiovascular safety of GLP-1 approval in place in 2015 or 2016. And that's because with diabetes drugs, like I said, there needs to be studies on cardiovascular outcomes and safety. And then moving forward to now, these drugs have been approved for, diabetes, approved for obesity, approved in terms of they've seen benefits in cardiovascular outcomes in patients who have diabetes. And so they're doing the same type of studies in patients who have obesity. So they're looking to see if there's any sort of cardiovascular outcome in patients with obesity, irrespective of whether they have diabetes or not. There's also other products in the pipeline. We talked about tirzepatide, which is more recent at the end of this. It was approved last year for basically obesity, and it's the combination product. So it's not just GLP, but it's GIP, which isn't on this timeline. What you do see here is that there are additional studies regarding GLP, looking at various different diseases. So HFpEF, PAD, NASH, a whole slew of things. So I feel like there's always like news around GLPs, like new things that's happening with GLPs in terms of the benefits and things like that. So you're gonna probably continue to hear more benefits around GLP because there's a lot of trials that's being studied right now on various different diseases. So that's kind of a high level overview of kind of the journey of GLPs, because it wasn't intentionally made or discovered for obesity. It really was for type 2 diabetes. But what we found with a lot of different drugs is when you're studying for a specific condition, you may stumble upon a benefit for a different condition. And in this case, it would be obesity, kind of why we're using it for obesity now. All right, so I wanted to compare the different GLPs just so you can get an idea of why certain GLPs are being used more than others. We talked about liraglutide already in terms of kind of their percent weight loss, which is a lot less well, not a lot less, but pretty much less than semaglutide and tirzepatide. And so that's why you don't actually see it as much. Additionally, a lot of these medications, we talked about how these diabetes medications are being studied for cardiovascular effects. They're also doing the same for, again, the obesity, for patients who have obesity, irrespective of whether they have diabetes or not. Um, in terms of cardiovascular and renal effects, because renal effects is also something we look at for all patients who have diabetes and obesity, because again, like I mentioned before, obesity have patients who are accompanied with other medical conditions. So in terms of liraglutide, there is benefit seen in MACE. MACE is essentially major adverse cardiovascular effects. And they look at basically it's a composite of like all the different cardiovascular disease, such as like stroke and things like that. But that specifically has been studied for patients with type 2 diabetes, not necessarily patients who are using liraglutide for obesity, irrespective of whether they have type 2 diabetes or not. So just keep that in mind. That is the same with the renal benefits. So the renal benefit is seen in studies for patients using liraglutide for the treatment of diabetes. There isn't really any study out there to look at obesity and the effect of liraglutide for the cardiovascular and renal benefits. The only trial really that is out there is the SELECT trial that studied patients with pre-existing cardiovascular disease without diabetes, specifically looking at semaglutide compared to placebo. And they saw benefits in the MACE outcomes as well as improvements in patients' symptomatic HFpEF. So there are symptoms in terms of signs and symptoms for patients who have HFpEF. Tirzepatide, I mentioned how it was newly approved. There are studies that are currently under investigation right now as it relates to cardiovascular outcomes in patients on tirzepatide who have obesity with or without diabetes. So there are studies being done right now. It is under investigation. However, there was recent publication for a phase 3 trial with benefits seen in patients who have HFpEF. So I can only imagine that once they conduct a phase 4 trial, you're going to continue to see this benefit, and I would imagine that eventually they might be approved for HFpEF benefits. But we'll see. This is just data from phase 3 trial. There's still another phase that they have to do, which is the phase 4, a larger trial with more folks. And so we'll see what that looks like. Like I mentioned before, there's a bunch of trials being done right now. In particular for tirzepatide, looking at various other potential benefits or not benefits of tirzepatide, and one of which is also renal effects. But they're also looking at liver and a slew of other things. So that's kind of a high-level overview of the various different GLP products. I'm actually going to talk a little bit more about that in a bit too, more from a logistical prescribing perspective. But there is a head-to-head trial. A head-to-head trial is basically a trial studying two different drugs to see kind of which drug is really better. And between the three, the only head-to-head trial out there is really with semaglutide and liraglutide. And what you see is that semaglutide actually has a significantly more weight decrease than liraglutide does. So you can see in this study the mean weight change from baseline to week 68. So it's kind of a pretty decent amount of duration. Semaglutide has shown a change in 15.8% in weight loss, as opposed to liraglutide, which is 6.4%. And then placebo is 1.9%. So this is why you probably see semaglutide being used a lot more than liraglutide. There really is not any head-to-head trials with tirzepatide. However, I did find a study, a cohort study. So what that means is these investigators looked at electronic health records. It's not like your randomized control trial like this, but these investigators looked at data from electronic health record. It was like a large number. And they compared semaglutide to tirzepatide, and they found that tirzepatide did have a better decrease in weight loss. However, that's just something for you to keep in mind. I wouldn't take that and say, oh, tirzepatide is better, and this is my support for it. But it gives you a kind of idea of what is being seen looking at data from electronic health records. So there's obviously flaws with cohort studies as opposed to a randomized control trial. And so, but I figured I'd give you guys information on that just because that's really the only thing out there comparing semaglutide to tirzepatide. I would imagine that maybe in the future there might be head-to-head trials, but as of right now, there isn't any other than the semaglutide versus the liraglutide in the STEP 8 trial. So moving on, clinical pearls. So there's a lot of different things that we have to take into consideration when prescribing and providing patients, prescribing GLP-1s and GLP-GIP-1s to our patients. The biggest thing is promoting open communication. You want to work with the patient. You want to make sure that they know exactly what they're getting into when they're getting this medication. So ensuring that there's open communication with the patient. And the reason why is I'll tell you why shortly, but you want to basically provide upfront expectations and set realistic goals for your patient. The reason why I'm saying this is that, there's a lot of noise out there saying how great GLP-1s and GLP-GIP-1 is as it relates to weight loss, right? But there's steps that has to be taken to ensure that the patient is getting the appropriate amount of weight loss in a certain period of time. They can't go from 0 to 100 and take the drug and then get like X, Y, and Z weight loss, right? It doesn't work that way. It needs to be done in a slow manner because of things that I'll talk about shortly. But you need to set that expectation with your patient ahead of time. If you don't, your patient might have an unrealistic expectation, and they might find that, they failed therapy because this was their expectation, when in reality, it's actually a slow progress to get to weight loss. And not only that, is not just using medication. Renee is going to talk about lifestyle intervention. Lifestyle intervention is extremely important in addition to pharmacotherapy for the management of weight loss. And so it is very important to have that conversation with your patient, set those realistic goals with your patient. One of the realistic goals or upfront expectation is, obesity is a lifelong medical condition. Like any other chronic disease, if you discontinue that medication, the likelihood of weight gain after treatment discontinue is actually pretty high. And so that is also a conversation that you have to talk to your patient about. This is the medication that you're likely going to be on for a very long time. The other thing about GLPs that we find in clinical practice is that patients have a hard time tolerating the side effect. The biggest thing is the nausea and vomiting. There are ways to work around it, and we'll talk about it when we talk about prescribing consideration. But patients, a lot of times treatment failures happen because of the side effect, because of the nausea and vomiting that our patient cannot tolerate. And so we need to educate our patient, talk to our patient about the adverse effect. These are things that if I'm prescribing GLPs to my patients for obesity management, I need to talk to my patients about. I mean, there's probably a lot more tips that you have out there, but these are kind of the 4 buckets that you really want to hone in when you talk to your patients about starting GLPs. And when I say GLPs, I'm also talking about the GLP-GIP combination product. Prescribing considerations. If you are a prescriber, there are certain things that you need to consider. The first thing first is you need to involve your patient in the treatment decision. I can give you an example. my mom's PCP wanted to put her on a GLP-1, right? She has type 2 diabetes. She's well controlled, but she's on the heavier side. And she's older. So for older patient, it is a lot more difficult to just have lifestyle modification alone to lose weight. And so her PCP wanted her to kind of start GLP to help her with that weight loss. But my mom was like, no. She's traditional. She is on Western medicine, but she grew up with Eastern medicine and the fact that there's needles. And historically, there was a bad rap with like weight loss medication, adverse effects. I'm a pharmacist. I'm her daughter. I try to talk to her about it. Her doctor tried to talk to her about it, but she was not about it. So if your patient's not about it, it's not going to work, right? So you need to involve your patient in the treatment decision. Many of our patients now are interested in it, but a lot of our patients have needle phobia, right? The GLPs, the GLPs used that's approved for obesity is a needle, is an injectable, right? That is the biggest barrier for a lot of our patients. In addition to cost, which we'll talk about in a little bit. But you want to involve your patient in the treatment decision. Otherwise, you're going to fail your therapy. Collaborate with other healthcare professional. If you're a prescriber, if you're a clinician, right, we know how difficult it is for you to be able to follow up with the patient in an appropriate time frame. We know what your schedule looks like. We know your limited schedule because there's so many PCPs available. So collaborate with other healthcare professionals. Does your clinic have a clinical pharmacist? Is there a way that your patient can see a clinical pharmacist to help with the titration of the medication and monitoring of the medication? Does your practice site have a nursing standing order? So at Common, one of our initiatives for GLPs is to have a nursing standing order to increase and titrate GLPs, but also to monitor side effects, right? These types of visits we can have more frequently because of the resources that we have, as opposed to trying to make appointments with the primary care provider. The GLP titrations for nurses is very similar to if you have a protocol for insulin dose increase, right? It's pretty much very similar. So can you use those? Can you collaborate other healthcare professionals to help with the management of GLP for your patients? Some other considerations to think about: dose titration. So dose titration is an important concept to think about. And that's because there's two prongs to it, right? The efficacy and tolerability. So first off, in terms of efficacy, a lot of the initial doses for these GLPs do not provide therapeutic effect. And that's something that I find that a lot of clinicians and patients and folks don't really know. And they tend to potentially stay on the lowest dose, the initiation dose, and they don't see any progress. That's because that's not intended. The initial dose isn't intended to give you therapeutic effect. The initial dose is really to help patients tolerate the side effect of your GLPs. Like I mentioned before, GLPs can cause nausea and vomiting, right? It's huge. And so there's a slow titration in terms of the GLPs. Efficacy and tolerability. So basically, one of the things that we learn in pharmacy school, and this is very evident for this particular product, is that you want to start at a low dose and go slow. So titrate slowly based on the patient's tolerability, right, of that medication. And that's why it's important to have touch points with your patients. And so that's why it's important to collaborate with other healthcare professionals, because of those touch points that you have to have with your patient. Other things to consider is the device. Semaglutide and tirzepatide, the Wegovy and Zepbound, are pre-filled single-use syringes that has preset dose. Your liraglutide, the Saxenda, works very similar to an insulin pen, where basically you need to prescribe a needle, a pen needle, so that the patient can attach it to the pen, and then the patient will have to adjust the dosing based on what dose they're supposed to have. Issues with access to GLPs and the combination product. So shortage is huge, is a huge topic. We'll talk about what is being done as it relates to compounding semaglutides. But basically, to help with shortages, there's a couple of different things that's being happened. There's compounded products that we hear about all the time, but there's issues related to that. Manufacturing facilities. So Eli Lilly and Novo are expanding their factories to hopefully compensate for the demand of these products. Um, Other issues as it relates to access to GLP and the dual product is affordability. There's issues around insurance coverage. When it first came out, you see a lot more issues and barriers as it relates to insurance covering those products. But right now, a lot of insurance are covering these products. It might require prior authorization, so the providers need to submit paperwork to justify why the patient needs to be on this medication. Um, there's financial aid through the pharmaceutical company if insurance don't pay for it and the patients have to pay out of pocket. So those are some patient assistance programs that can help with the affordability of the product. However, it can still be expensive. Coupons are also available, but again, it could be very expensive for some of your patients. So one of the things we think about is kind of the the issue around looking at SDOH for your patients who are able to afford it, right? That's great, but there's going to be a lot of your patients who cannot afford these medications. And so that becomes an issue for your patients who, have low income, are not able to afford medications and things like that. Other ways manufacturers are improving access to this product is an initiative called Direct to Consumer. Eli Lilly had just announced this Direct to Consumer where patients can actually get the medication directly from Eli Lilly. And there's obviously a charge based on your copay. And if you pay out of pocket, there's a certain amount of money. Right now, I know Eli Lilly is doing it for GLP specifically for the treatment of type 2 diabetes, but I would imagine that that would be an opportunity for the treatment of obesity as well. Some other things to think about, Victoza, generic liraglutide has been available as of June 2024, this past June. And so there's opportunity for a generic version of a GLP. However, keep in mind that Victoza is approved for type 2 diabetes, not necessarily obesity. But I won't talk about off-label use. One of the biggest things with the compounding products is that you can see here's the letter from Novo Nordisk that don't recommend the use of compounding products. The issue with compounding products is it being compounded at a compounding facility? So traditionally, products can only be compounded if it's not available in the market. In this case, because of shortages, there are abilities for pharmacies to compound specific products. However, it shouldn't be a mass production, which is kind of what I'm hearing that's happening right now. And it may not even be done at a compounding facility, a compounding pharmacy. Compounding pharmacies are regulated and they're expected to comply with good manufacturing practices. But some of these places where you can obtain semaglutide, compounding semaglutide, we don't know if it's from compounding facilities. Or appropriate compounding facilities. We don't know what the compounding product is. We don't know where that source is coming from. And so we don't know, as a result of that, we don't know what the safety, efficacy, quality, purity of those products are. And so those are things that we need to take into consideration as it relates to compounding products. Because we don't know about the safety, efficacy, purity, quality of the product, it's going to cause adverse effects to our patients, which you might hear being reported. And then widened disparities, like I mentioned before, these are usually compounded products or things that patients pay out of pocket. So for our patients that can't pay out of pocket, it widens the disparities amongst patients who cannot afford paying cash. So wrapping up my presentation, because I definitely went over. There's a lot of different products in the pipeline right now that's being studied. You can see here, this is actually from an article in 2023. So as you can imagine, there's stuff that's coming out. Even like there's stuff that probably has been published and approved, such as tirzepatide, but there are things in the works. One of the biggest product is going to be this triple G, or this triple hormone receptor agonist. In a phase 2 trial, it has shown to show significant weight loss. So you can see here 24.2%. It was from a phase 2 trial, so keep in mind that's only a small group of folks that have the disease, and the purpose is really to see if it's efficacious and if there's any side effects related to that. So the study was basically it enrolled roughly 300 patients, and it was studied for 48 weeks. Phase 3 trials are being done right now. It's being conducted and recruited. So it'll be interesting to see what comes out with this triple G product. So it's basically a GIP, GLP, and then the third mechanism is it's a glucagon receptor agonist. And so they're hoping that this will help with weight loss. So that wraps up my section of this presentation. I'm actually going to hand it over to Dr. Renee Rogers to talk about lifestyle intervention.
Awesome. Thank you. Let me grab my slides here and share. All right, fabulous. That was an awesome start. I wish I could present with someone like you, Phung, like a pharmacist every time, because I think we can stronger together. So that was an amazing setup and such great information for everyone. And as mentioned, I'm going to dive into the lifestyle portion of this. And I ask anyone attending, I know the slides are going to be shared with you, but out of respect to the authors, please make sure if you use any of this information in your communications or articles or other things that you cite sources appropriately. A lot of people do a lot of great work in this area, and we want to make sure science-based information is spread appropriately. I will disclose quickly that I am a consultant instructor. I have my own LLC, but I do work with a company known as Wonder Health. However, that will not impact anything that I'm presenting today. Really quickly about me, I am an exercise physiologist by training. I've done everything from personal train to group exercise to working in medical fitness facilities. But as someone who struggled with their own body weight, for many years, I was very intrigued at the role that lifestyle, specifically exercise, played in the relationship of body weight, and realized after treating thousands of patients that it wasn't enough and we didn't know enough. So I went on to get my PhD, specializing in obesity, comprehensive obesity care, and behavior change strategy. So I love the biology. I'm a science geek, but I also really care about the human in the center of everything. So as mentioned in my bio, I like to say I take a biobehavioral approach with everything. So a lot of what I'm going to present to you today is starting out with talking about biologically the role that specifically physical activity, but we can't think of it in isolation. We have to consider the diet with it as well. But the role that the biology has, these medications, obesity treatment related to the biology of the body composition specifically for our 30 minutes that we have together. And then I'm going to touch on what I think is extraordinarily important, which are the behavioral considerations from some of my own data that I have references in the slides for you related to patient perspectives, how patients feel related to lifestyle when taking these medications. And hopefully this will help us think a little bit, better about how we talk about and how we prescribe exercise. I have EXRX, or exercise prescription, or intervention targets as we go forward. So hopefully you get a sense of where I'm going with all of this. But I want to leave time for questions. So hopefully I'm not going too quickly through this. But we talked about this as being the critical role of lifestyle as a foundation. And, thank you, Phung, for saying earlier, how important it is for lifestyle to be a part of the pharmacotherapy. But the bottom line is lifestyle truly is the foundation for no matter what the treatment pathway is. And to further emphasize what was already said, we need to remember that patients taking these kinds of medications it's a shared decision between the patient and the medical provider. And that medical provider needs to be someone that knows the patient, understands their history, has the beautiful conversation to really understand, as Phung mentioned, is this culturally, personally, from a value standpoint, right for me. And that is so critically important. So this is a shared decision. And traditionally, we've thought about this as three pathways, right? Unfortunately, I'm going to say we've thought about this. It's lifestyle for obesity treatment or weight loss, it's pharmacotherapy, or it's bariatric or metabolic surgery. And that's actually not realistic. And the more that these messages keep continuing to be sent, as Phung put it beautifully, we're better together when we think about the combination of lifestyle and pharmacotherapy. And the reality in clinical practice, what we see is that many patients taking these pharmacotherapies or having metabolic bariatric surgery absolutely positively should be taking on lifestyle, which I'll talk about for some of the reasons here in a moment. But then the flip also happens. We have many patients that start on a trajectory of lifestyle therapy. And I forgot to mention, we're also seeing many patients with metabolic bariatric surgery that are after surgery, post-surgery, after several months, now going to pharmacotherapy to help with maintenance or continued weight loss on their journey, which is really important. And we're trying to understand this relationship better. But it goes in reverse, right? Lifestyle, a patient may lose a certain amount of weight through lifestyle strategies and then need to move to pharmacotherapy as they age or if they have additional weight loss to lose. Co-conditions, as we've heard, or same goes for lifestyle to bariatric surgery. So this is a complex relationship. Obesity is a chronic disease that is quite complicated. The treatment pathway looks different for everyone. But in the center of lifestyle, what I'm primarily focusing on today is physical activity. But again, physical activity does not sit in a vacuum by itself. It's critically important that we're considering nutrition and dietary counseling. And I will say, and as you've heard, obesity is complex. Many patients with obesity also have type 2 diabetes or heart disease, as you've already heard, or other kidney, liver complications. Nutrition dietary counseling should be happening from our registered dietitians or under the supervision. We want to be really careful. And what I think is critically important in this relationship is behavioral counseling. And I'm not just talking about, behavior change strategies to get patients to do lifestyle behaviors. RDs and exercise physiologists, they know how to do that stuff. I'm talking about the behavioral, emotional well-being support that patients that are whether they have mental health conditions tied to, their obesity status is one piece of it, but also as their body changes, as they lose weight, there's the need for additional behavioral support and treatment, which is critically important. So we have to think about how these all interrelate with each other. And when we talk about lifestyle, we want to make sure that we're thinking comprehensively. Do you have the people in your network to help you refer the right way, referring for that patient and what the patient's needs are? But again, we're going to really hit on the physical activity. So as I mentioned, I want to target this from three key areas. First, the biological, the behavioral, and how we can have better conversations. And let's start with the biological. So as you've already heard from our first presentation, these medications, and I'm speaking specifically to that second liraglutide on or third generation, and the incretins like we've been talking about, or sometimes you'll hear being called nutrient stimulated hormone therapies because of all the different receptor agonists and all the different things in the pipeline right now. As you've seen from the beautiful slides that were already presented, is that we have weight loss is definitely something that we're seeing very highly efficacious. We have better control of type 2 diabetes. We have reductions in cardiometabolic risks and specifically reductions in adiposity. And that's one of the really critical important, points with all of this. But one of the things, and I have an X next to it, because as everybody boasts about all the benefits, we do have some concerns about reductions in lean mass. And a really great paper by Wadden and colleagues looks at this and estimates that with semaglutide and tirzepatide specifically, we're seeing reductions between 25 and 40% based upon DEXA data. So, which is really considered many times to be that gold standard, right, in terms of overall body composition analysis for obesity treatment. This is higher than what we see with lifestyle interventions alone. Typically, lean mass losses are somewhere between 10 to 15%. Now, remember, even with lifestyle interventions that may or may not include physical activity, there is still a reduction in lean mass. So we want to be careful with that, and that'll make sense here in a second. But one thing that is additionally important is we need to consider reductions in muscle mass. Now, the whole world is exploding right now saying these drugs are dangerous because patients are losing muscle mass, and this is a concern. The reality is, folks, I have a question mark next to this because we don't actually know how much of that lean component is truly muscle mass. Those studies are currently underway. I'm happy to say my group is doing some of this work directly at the University of Kansas Medical Center. But lean mass is a compartment of the body. So I'm going to warn you, and I'm going to say, let's be very careful when we talk to patients that we recognize that lean mass is not the same thing as muscle mass. We have to realize that lean mass is one component of the full compartment. I'm sorry, muscle mass is only one component of the full lean mass compartment, right? So the lean mass compartment is made up of muscle, bone, water, organs, other connective tissues, right? And anytime we lose weight, even with a really great comprehensive, lifestyle program, which I can tell you, I've been involved in many of these clinical trials where we have patients exercising at high doses, highly rigorous physical activity, well-controlled hypocaloric, well-balanced diet, eating enough protein, doing all the right things, they still have reductions in their lean mass component. So let's talk about this a little bit more. And, we mentioned this, and this is a paper that's published in Obesity that my great colleague, John Jakisik, and myself and Dr. Tim Church were involved in. But this is a really nice way to kind of take a look at this relationship of physical activity, to reframe how we talk about it. So we're not making claims that we don't have evidence on. So when we look at these highly effective medications, we know, you saw it already, there's a reduction in adiposity, even visceral adiposity. And that reduction in adiposity-related chronic condition is improving health and well-being. We also know, as I just mentioned, that there is an absolute reduction in lean mass that may be higher than what we would see with a lifestyle intervention alone. We don't quite understand that mechanism yet. There's lots of studies being done to understand it. But when it comes to physical activity, which includes exercise and both aerobic and resistance activity, and I'm going to kind of group those together right now because those haven't been teased out in the study specific to these medications yet in the work. We know that you can also reduce fat mass at some level, and we know it's some light that you may be able to preserve some of that lean mass, but likely there's still going to be a reduction in lean mass when it comes to physical activity intervention. Now that we do still, though, see a reduction in sarcopenia-related chronic conditions. So sarcopenia is that reduction in high levels of muscle mass reduction, lean mass reduction that can be leading patients down a negative pathway. We have to care about sarcopenia, especially with our older adults. So there is something there in terms of the role of exercise in helping with this sarcopenia or sarcopenic obesity. However, orange is important on this slide. We know that with physical activity, there are improvements in muscle quality and function. And we have tons of evidence, especially from our bariatric surgery literature and from studies across the board that demonstrate that even with loss of lean mass, even with substantial weight loss in a hypocaloric state, we can improve muscle quality and function. And again, this improves sarcopenia risk. This improves health and well-being. And at the end of the day, we know that there are a ton of benefits of physical activity beyond that has anything to do with the weight loss. And this is critically important now that we have such highly effective agents out there that are helping with the weight loss at a level that they never have before. We can be talking about exercise from a different light now from around all these other health benefits as well. So it's not just about stopping or attenuating muscle mass. But what's the problem? And I say it's what we don't know yet. And there's a lot of claims being made right now, but the reality is there are a lack of studies with contemporary nutrient stimulated hormone therapies or your GLP-1s that are really looking at well-structured, controlled exercise and lifestyle programs. They've not compared aerobic. They've not looked at resistance specifically. They've not monitored the dietary intake at the same time. There's not well-controlled clinical trials out there yet. None of them to date have had direct measures of muscle mass. So this is through methods such as muscle biopsy or muscle MRI or a method that we're using, which is the diluted creatine method to get total body skeletal muscle mass. Those are the kinds of things that we're not seeing in the actual literature yet. Lots coming, I can tell you, because it's a hot topic. But again, the problem that I think we have is we're recommending it, and we're hearing claims out there from people saying, my fitness program is going to stop muscle mass loss. One, we don't even know how much of the loss is muscle. And two, we have no studies to show that we have that. So we want to be really careful. Should we be promoting exercise? Absolutely. And let's get into that from a different standpoint. So what we know and don't know about exercise, let's talk about resistance training, but I want to use the term muscle health because I think that goes back to the slide that I just presented. How can we improve the quality of the muscle that we have for multiple metabolic and biological benefits? So I'm going to bring you back in time to 1991 because a lot of the work that we're doing in this new space, because there aren't clinical trials, we're working as we develop research programs to truly understand what have we known about obesity treatment and exercise and lifestyle, and how does that help inform us forward? And I want to bring you back in time to 1991 when the first very low calorie diet studies came out. And I'm sure, some people know all about this because, right, when we do an extremely hypocaloric state, it could be 500 calories a day. We know that there are, yes, major metabolic health benefits and weight reduction when we drop the calories this low. Can you do it for a long time? Most people can't. Is it still recommended? Yes, for some people to jumpstart their weight loss, whether you agree or disagree, but we're going to use this as an example. So in this particular study, what you have is a diet-only group, a diet plus endurance training or aerobic training, a diet plus resistance training group, and a diet plus a combined training group. And this was a 3-month study, 90-day change. And what you can see is across all of these groups, they all lost fat mass specifically. This was a specific measure of fat. And they all lost about the same. So one point to demonstrate to you here is that even when you have such a reduction in caloric intake, right? Exercise doesn't always add additional weight loss to the relationship. And that's really important to remember as we think about these highly effective agents. Change in lean mass, same thing happened. Even though we added exercise, even specifically resistance training, there was still an equal reduction across the board in lean mass. Again, likely because the body either didn't need the additional lean mass to support the adiposity that's been lost, and or the hypocaloric diet, not getting enough protein, is impeding the ability to actually build that muscle or attenuate that muscle mass. So is that the whole story? No, it's not. And this is where muscle quality comes into play. And this is where we get our signals from. Notice in the red arrows on the screen, both these groups had resistance training added to the very low calorie diet. When we measured strength, their strength went up. Strength is an important quality of life measure that for our patients, it's really important. So even though they lost lean mass, improving their strength was notable. Same goes for aerobic fitness. That's what's being pointed out in the red arrows. The groups that had a level of endurance training had improvements in their aerobic fitness, even though they lost muscle mass. So it is still possible. Now, I will caution you and say, is there a point where losing too much lean mass is important? And the answer to that is absolutely. This needs to be investigated in different populations, in different racial and ethnic groups, in different age categories. We need to be thinking about all these things as they come together. But as a starting point, I think it's really important for us to change the conversation to be about quality and what you can do and what exercise can do in the relationship. Stop saying we're going to stop muscle mass loss. We don't know that yet. So be really careful when you're talking to patients about this. I want to bring up the study of liraglutide that I think is one of the only exercise randomized controlled interventions that's out here. And you can see that it starts out with a 8-week low calorie diet. I'm putting the design up here for you to start. Then we have in the colors, the placebo versus an exercise only placebo group, a liraglutide only group, and an exercise plus liraglutide group. And this was a 1-year intervention. And then at the end of 1 year, they took everything away. And as you heard from our previous example, when you take away any kind of treatment, no matter what it is, you're going to expect the weight to come back up. So I want to show you some of these outcomes because this is an interesting signal for us to think about. So I do want to caution you though, because one of the things about this design that's a little complicated is because they lost weight in the first 8 weeks, it skews a little bit of the body composition potential to look at really the role of exercise, but let's take it for what it is. These colors are identical to what you saw on the design slide. And if you note the blue and you note the red, the blue is the liraglutide only group and the red is the exercise plus liraglutide group. And what you see across the 1 year is that the group that was taking liraglutide continued to lose weight, and then we saw them plateau and for the most part maintain that weight loss across the year. The group that had exercise added actually continued to lose weight as well, continued to lose even more at about, an additional 6-month point, and then started to plateau out, versus the exercise only group truly maintained, which we know exercise can be helpful for weight loss maintenance, and the placebo gained. Now, this is very, very promising because we look at this and we say, great, exercise will add more weight loss to GLP-1. But let's be careful, as we heard from our last presentation, when you did the head-to-head semaglutide liraglutide trial, right, that you saw from the STEP 8 trial that was presented currently, we see almost doubling, if not more, weight loss with semaglutide. So going back to those very low calorie slides that I showed you, when the magnitude of weight loss is much higher, we're not certain that exercise will continue to have an additive effect in the relationship. So again, another claim that we don't want to make is that you'll lose even more weight if you exercise. That's not the reason why it's on the FDA label to combine these medications with physical activity and exercise. It's there for that muscle quality and that muscle health perspective. And then, as you might guess, as we showed here, after that intervention standpoint, where we take everything away, you notice that all of these slants on the right side of your screen, we see our trajectory start to go upward. However, that red line, that exercise plus liraglutide group, is a signal that maybe this will help with the weight regain factor afterwards. Again, will it be the same situation with semaglutide or tirzepatide or retatrutide or any of these other new agents that are coming out? We don't know yet. So hopefully we'll be having more data on this relationship soon. The other thing I want to mention about this study is this was not specifically a resistance training study. It was not specifically an aerobic study. It was kind of a mishmash of just all different kinds of exercise, patient selected, different kinds of things, not well defined and or controlled. So limitations with everything out there. And I'm just going to skip through this for time, but again, let's get to the problem. So what do we know yet? Is it all about resistance training? Maybe. And we know that resistance training, the specificity of doing resistance training may have better indications on muscle strength, right? That component of health. But we've seen even from bariatric studies that even with aerobic training, we see improvements in muscle bioenergetics and muscle health and function and quality of life. So it may not just be about this is the perfect mode that goes with a GLP-1. It may need to be more about what does the patient need to feel and function their very best and prescribe exercise from there. We'll talk about better conversations in a minute. Is it about quality or quantity? I think we have some research to do. My guess is it's more about the quality from what we've learned from previous studies, as I showed you. And we have to remember, it's not just about exercise. When we're in a hypocaloric, nutrient deficient state, it plays a difference. And if patients are not getting enough fuel, definitely not getting enough protein into their systems, which our data shows most are not getting enough protein, not getting enough fuel on a daily basis, that it will be very, very hard to build muscle, but we can still build strength and muscle quality. So how do we find the appropriate target? How do we navigate this? There are so many unknowns, and you would think based upon the noise and everything you hear out there that we have all these answers. We don't, and that's okay. It's important to have these honest conversations. So this is where it goes back to balancing the biology and the behavior. I just told you all about the biology and all the things you need to think about, but let's think about the human. Let's think about that important person in this relationship. So what do we know about behavior and how patients feel when it comes to lifestyle? And this comes from some of the qualitative data that I've done in our clinic. And I've published this in some of this data in two different spaces. Again, please credit if you use any of this information. The American College of Sports Medicine has been extraordinarily supportive of this work. And in their Health and Fitness Journal, we have two papers currently. And more to come, I will say, not in their journal, but others. But this comes from a survey where we sent it out to patients through our comprehensive weight loss clinic, where we have medical management of obesity and lifestyle management combined. And this was combined data from survey results and qualitative interviews with a large number of patients about how they feel when it comes to exercise and lifestyle behaviors. So in a nutshell, this is a small sampling right now. We haven't looked at the full sample yet, but these are mostly patients taking liraglutide, semaglutide, or tirzepatide in their mid-50s. These are mostly women. And as you can see, on average, they've lost 19 kilograms of body weight, pretty substantial losses of body weight in this group of folks. And in terms of their physical activity behaviors, actually, on average, this is surprisingly good to see that people were active or qualified themselves as being active about 2.8 days per week. But unfortunately, 66% of our sample were not meeting the recommended 150 minutes per week of physical activity, according to our national guidelines. And most of them are still doing aerobic activity, which really makes sense because that's what we've recommended for years in the weight management space. We talked to lots of folks about starting out by getting out and moving more by walking. So it's not surprising, and very limited number were doing any form of resistance exercise. What I think is really important for all of you to hear is that when we talk to them about whether or not they think physical activity is important, we know that, and if you look at these categories, low is red, gray is moderate, high is blue. So if you rank it low, you think it's not important in your weight management relationship. But if you mark it high, it's very important. And you see that a large sample, almost 63% of the folks say it's important. Rank physical activity as being important. And we see that if they say it's important, they do it more days a week, they do it for more minutes at a time, and they're more likely to hit the public health recommendation. So that's good, right? Our patients are saying it's important. However, there's a disconnect with confidence. And we know that confidence or self-efficacy is a major predictor in actually doing physical activity. Same thing here. We see a lower percent. 46% of people tell you that they have the confidence to do it. And the same relationship applies. If they tell you they have confidence, they do it more, they get more minutes, and they're more likely to hit the public health recommendations, which is going to take us right to that muscle quality improvement in health that we're looking for. But there's a disconnect, folks. Lots of patients know that it's important. They've heard you tell them that it's important 150 million times, like a broken record. We need to work more on helping our patients feel confident in doing it and improving their self-efficacy. And that's the next challenge for our profession. So how do we do that? And I started to do my patient interviews. These were semi-structured interviews. I really dove into a lot of this because I wanted to understand these barriers a little bit better. So I'm going to go through these quickly for time. But first off is discomfort. Most of the patients taking these medications still report that they are uncomfortable with the way that they look while they're exercising and the way that they feel during exercise. And there's a lot of things that we can dive into this, and this doesn't really account for everyone. These are just some of the larger themes that have come up, but they're also very, very uncomfortable exercising in public spaces like gyms. So when we make a recommendation, you need to go to the gym and join the gym because you need to start doing resistance training because it's going to help you stop muscle mass loss. Hopefully you're not going to say that anymore. But if that's the pathway that you've taken as a clinician or a recommender of lifestyle behaviors, you might want to pause and ask them, are you comfortable exercising in front of other people, as a starting question to think about? Self-efficacy, as I mentioned, confidence is a big player here. They're telling me that they lack the knowledge and skills to exercise. They've never been an exercise person. They have a negative past experience, or they have safety concerns, and that's either related to orthopedic conditions or stemming from maybe carrying excess body weight and adiposity for a long time, or having type 2 diabetes, or having a heart condition, or having another comorbidity or condition, it's not just about their weight, right? So this is where we want to make sure we're recommending to certified clinical exercise physiologists that truly can look at this from a multifaceted approach. Even if it's not you, you know where to help guide someone on that trajectory. Stigma is big in our space, folks. And I think the one thing about this new class of medications getting so much popularity is that it has opened up the conversation about how we need to be treating humans with obesity better, helping them to get better, unstigmatized support. We need to release weight bias from our facilities and our treatment centers and realize that people are not taking the easy way out by using these medications, as you've heard. Sometimes they're necessary. Obesity is complex. So I encourage you all to examine your own personal weight biases. And we are all very good, many of us as well, about lifestyle and what lifestyle can do. And we've had individual clients in our facilities do well with lifestyle strategies. But we need to realize and let go of some of our own intellectual biases. I love that term. Ted Kyle uses it in the Conscience group. And we need to make sure that we're not promoting weight bias by thinking that someone failed because lifestyle didn't work for them. This is where pharmacotherapy can really be a game changer to help level the playing field for persons with obesity. They also feel like their size and their co-conditions or morbidities influence activity counseling. Many reported to me that lots of them work with a dietitian in our clinic, that their dietitian doesn't know how to talk to them about physical activity and exercise, or their behavioral coach just gives them general recommendations or says, you're not ready for that yet. You need to lose more weight. They hear a lot. So how can we make sure that we're actually asking the person what they're ready for rather than not making an assumption? And again, if you don't feel like you're prepared to talk to them about physical activity given their related conditions, how can you refer to an appropriate clinical exercise physiologist that can? So I love this quote. I say this every time in my presentations, but one of my patients said, that I spoke to on this, if I knew you were an exercise person, I never would have talked to you. And me, of course, why would you say that? How can I help you? And they said, people that act like everyone can do it alone, meeting with lifestyle, don't understand lifelong obesity well. And it's sad to hear, people say that. So when I dig in a little bit deeper, they say social media. And this comes from seeing people say, here's nature's Ozempic. And if you eat these foods, it does the same thing and all these stuff, right? Or you're taking the easy way out, or you can do it alone. And it doesn't really represent them. So what's out there in the media, not just social media, is really, really impactful. I had another person say to me, can you help me get access to an exercise person that knows weight loss and is empathetic? 3 trainers told me that I don't need those drugs. My method works better. And the saddest part about this is the patient said to me, I never went back. So we have to remember in obesity treatment that one size does not fit all. One size absolutely fits none. And that's where I am so excited. And I know I've had people on LinkedIn say, how dare you? You're an exercise physiologist. How can you go down a pharmacotherapy path? The reality is I am an obesity advocate, treatment advocate. I want every patient to get access to what they need, whether it be pharmacotherapy, metabolic bariatric surgery, or lifestyle interventions. We all should be on the same team to give persons with obesity the best chance. So I want to encourage you to make everything you say and do in this space person-centered, not method-centered. There's a lot of businesses popping up around GLP-1 and GLP-1 programs and all these kinds of things. And that's a very solution-minded standpoint. And we really want to think about creating a support for patients. And trust me, more of these qualitative interviews I do, the more patients are saying, I see a GLP-1 program pop up and I'm like, get me out of here. This isn't about the drug I'm taking. This is about me as a person on my weight loss journey. So a couple other things that we've learned is, yes, folks are concerned about loss of strength. Some even ask if it's muscle. We've also heard them say things like they're concerned about their energy levels, which is one of the side effects we've heard potentially, or feeling tired or more fatigued. It's variable. So I've looked at these as both being relevant targets. And actually what we see is that patients that report these things in our data are actually patients that have lower levels of physical activity. So there is a correlation between those that seem to be moving more in their lifestyle and not feeling as fatigued and not feeling as weak. So again, that may have to do with that muscle quality. So we're so short on time. So I want to talk about better conversations here quickly. So how can you take this information from what we know right now and have better conversations about lifestyle, whether you're a health coach, you're a dietitian, you're an exercise physiologist, you're a provider, anyone in this stream of space, how can you do this? And I love to say, ask the patient, what are your previous experiences? Don't assume that they don't know how to exercise, because trust me, I had 50% of my patients say, been there, done that. I've done every diet lifestyle program out there, right? I am at the next level of needing something else. And then on the flip side, 50% have never exercised before. So let go of your assumptions. Ask the right question first. 2, what do you like and dislike when it comes to physical activity? The worst thing you can do is say, go start a resistance training program. If they had a bad experience, you should understand that. You should see where they're at. They may tell you they hate the gym. Why would you send them to a gym, right? What are your fears? What are you worried about? How's your energy? Are you noticing that your energy is impacted? If that's something relevant that someone values and that's impacting their quality of life for their day to day, I can tell you that having a conversation about physical activity that's tied to that relevant target is really going to make a difference in terms of their ability to connect in a better way with physical activity. And then lastly, refer for the individual, not the service. We get very tied up in, okay, exercise, go to the gym. A dietitian recommend this supplement or this program or this thing. When the reality is stop and really say, ask the person, what's the person telling you? If they're afraid of the gym, don't tell them to get over their fears. Find another way to talk about physical activity. Make sure you're referring for the person, not the service. So the key targets that I want you to think about are confidence, self-efficacy that I mentioned. Target those previous experiences. Ask questions about their relationship with physical activity, where they want to go with it, how you can help get them there. Let them guide the conversation. And also think about environmental considerations. And I don't mean our global environment. I'm speaking of, are they comfortable in a gym? Do you know that the facility that you're recommending them to is great inclusive space for persons with obesity, that they're going to feel comfortable? The trainers are trained appropriately. I'm not talking about reading a 1-page or a booklet certification and getting a quick certificate. I'm talking about they have the right people on staff that understand these medications and are keeping up. 133, I think, was the number this morning of agents in the pipeline from preclinical through phase 3, which is insane. This space is moving fast. And the last thing that I'll say is this is an awesome paper that was just released, and beyond GLP-1, beyond nutrient stimulated hormone therapies, this is an update in the science and medical management and lifestyle considerations, specifically physical activity for the entire treatment of holistic obesity, that was recently published in the ACSM translational journal. So I encourage you to grab this, look at this, take this diagram. Wonderful reading material. Great. I will stop there.
Well, thank you very much. Wow. Let's everybody give them a round of applause for everybody.